Dear audience, welcome. I'm Maria Pellegrini. I work for the ERN-EuroBloodnet as Patients and Educational Manager. And I really would like to welcome you on behalf of the European Reference Network on Rare Hematological Disease, so the ERN-EuroBloodnet. And today is the 8th session of this webinar that targets patients and their families and is focused on aplastic anemia and PNH. So this program that consists of several webinars, indeed as said today is the 8th one, has been co-designed and coordinated by the ERN, but also by the Patients Association that I always would like to thank for having guided me through this great experience. So the PNH Support Group that is focused on PNH, and it's represented by Maria Piggin, that is also the ePAG of the ERN-EuroBloodnet, by Lichterzellen, that is focused also on aplastic anemia and PNH, and is represented by Pascale Burmester, and also EURORDIS. If you have followed the previously session, you will surely know that this program aims to disseminate crucial area related to those diseases, to aplastic anemia and PNH, among the patients community, in order really to give visibility to the medical services available in Europe, the recent quality of life, cutting edge advances in this field, and also the treatment option. As you also may know, each session is moderated by a duo of an expert physician and a patient representative who host the session together and lead the session together. Today, we are going to talk about life after bone marrow transplant for aplastic anemia and PNH. As said before, we have a dual speaker. So with myself, there is Professor Edgar Jost, that is the head of the Unity for Stem Cell Transplantation and Cellular Therapy, and who has also a position as Associate Professor in the Department of Hematology, Oncology, Hemostasiology, and Stem Cell Transplantation at the Aachen University Hospital. And then, as pre-announced, we have also patient representative, so Pascale Olivia Burmester, who was born in Germany as a Master of Educational Science. She is a aplastic anemia and PNH patient transplanted in 2013. And she has been supported since 2005 by co-founding a self-support group. She's indeed also the CEO of the German Foundation Lichterzellen. And I'm really happy to pass the floor to her for introducing this important session of today. And thanks to all of you for your attention.
Thank you, Maria-Angela. So today's topic is life after bone marrow transplant. And this could be an interesting topic for patients with aplastic anemia or the overlap syndrome. And it can be interesting for patients having had a transplant and also for those trying to find the courage to do one if the option is given. I myself had a BMT almost 10 years ago at the age of 42 with an unrelated mismatching donor. I had been living with aplastic anemia and PNH for 18 years and had had a second relapse when I decided for this procedure, even though the chances were not ideal. A lot of the issues you will hear in this presentation today, I have had to deal with, or I'm still dealing with, but for me personally, it's a much better life that I'm having now than living with the disease. But this depends on your health status before and after, obviously. So I could have gotten less lucky. Please raise your virtual hand if you would like to ask a question in between the presentation, and you're invited to interrupt or write a question in the chat and I will pick it up for you. Now I would like to pass over with many thanks for the time and presenting this important topic to patients to Professor Dr. Edgar Jost.
Thank you for this kind introduction. It's a pleasure for me to do that, because that's what I'm doing the whole day, treating people aplastic anemia or other diseases by stem cell transplantation or cellular therapy. Just one remark before I start. The title of the topic was Life After Bone Marrow Transplantation for Aplastic Anemia or PNH. Some of you know what it is. It's a paroxysmal nocturnal hemoglobinuria, but this disease is no longer transplanted when it's seen by its own. PNH is only transplanted if it's associated to aplastic anemia or some other diseases like myelodysplasia or myeloproliferative disorders. So all I would say now in the next few minutes will be applied for patients with aplastic anemia, and it's not limited to PNH patients. These are my conflicts of interest. This has been done. Housekeeping remarks. So the first part of my speak will be about results of transplantation in patients affected by aplastic anemia. And the second part will be focused on long-term follow-up. What is important 1 year, 10 years after transplantation. So results of allogeneic transplantation in aplastic anemia patients is the first part. Before going to the results, just for patients who don't know exactly what it is, transplantation, it remains one of the most complex treatments what is done in medicine, because you have a lot of issues what you have to resolve during the course of the disease and during the course of the transplantation. If you decide for transplantation for a patient, you have to find a donor for a patient. So is there an indication? Do you find a donor? If you have a donor and you have an indication for transplantation, you need a conditioning. Conditioning that means that it's a preparative regimen comprising most often chemotherapy and antibody treatment, and for some patients also whole body irradiation. That means conditioning. And there is a big discussion about the stem cell source. You can take stem cells from bone marrow or from peripheral blood. And in most patients with aplastic anemia, you prefer taking cells from the bone marrow and not from the peripheral blood, because you have more rejection, more graft versus host if you take cells from the peripheral blood. I will explain that a little bit more in detail later. You have an acute toxicity phase after transplantation during the first 2 or 3 months, but I will especially talk about the long-term problems what patients encounter when they have been transplanted for aplastic anemia. What are the results in terms of survival after transplantation? This is a Kaplan-Meier curve. I don't know if you are familiar with that, but this is a representation of results in medicine that is very often used. What you can see here is survival during time. So you see here results at the beginning of the study, after 5 years, after 10 years, after 15 years. And if you see 1 here of sometime there is 100%, that means that everybody is in the study at the beginning, and then if somebody will not survive, the curve will decrease, okay? And what you can see here is that you have some patients after transplantation that will die in an early phase around, you see here, this is 100%, this is 80%, between 5% when patients are transplanted with a donor coming from the family, this is this curve, and this is when the donor comes from a registry, okay? So some people die very early, but later there are most of these patients that will survive. This curve is a little bit too optimistic because these are very young donors. These are children and young adults that have been transplanted, but it was just to show you that results are good, but not everybody will survive the first few months of the treatment after transplantation. This procedure has still a lot of side effects. Not everybody will survive. And just to explain you also what it is, a Kaplan-Meier curve. survival is without any doubt the most important item after transplantation. And you see here also survival curves for patients that have been transplanted early in the phase of detection of the aplastic anemia. But some patients are not transplanted in the first time, but are only transplanted when the disease will relapse or if the disease is refractory to the first-line treatment, most often immunosuppressive treatment. This is to show you that you can wait with transplantation, but if you are only transplanted later when your disease relapses, results are not as good if you have been transplanted in a very early phase, okay? But you have still here also good survival curves, and you have what we call a plateau. You see after 2 or 3 years, if you have survived the first 2 or 3 years after transplantation, you will probably survive for really a long time. What is also important that survival is the most important item, that's no doubt about, but you have also side effects and you have sometimes a relapse of the disease. What you can see here on the right side of the slide is GRFS. This is a complex term that means that you have been transplanted, you have no relapse of your aplastic anemia, and you have no severe graft-versus-host disease. I will explain a bit later what it means. And you can see here that almost 65 to 70% of the patients that are young are free of relapse and have no severe side effects from graft-versus-host disease. But what you can also see is if you're older, above 40 years, it's not very old, but it's older than these young patients, results are not as good. You have more often relapse, you have more often graft-versus-host, and you have more often early death because this curve decreases very, very early. So a decision to transplant a patient is not the same according to the age of the patient. A patient who is 20 years at disease detection is treated differently to a patient that is 50 years old when the disease is detected. This is another representation, sometimes important for some of you. If you have been transplanted, for example, 6 years ago, and you want to know what will happen in the future, this kind of analysis will help you. For example, here, you are 30 years old, and you have been transplanted by a matched related donor, so by a donor coming from your family. Then you can see here, okay, it's 6 years ago, now I'm here, and probability to die from the disease is very, very low. It's 3 or 5%, okay? But if you're older and you had an unrelated donor, so a donor coming from a registry, you have still a significant risk to die from your disease even later, okay? That can help if you have been transplanted in the past to know, okay, what will happen in the future for me as a transplanted patient. Another question that is very often in the field of transplantation and aplastic anemia is a decision what to do first. Is it better to do a bone marrow transplantation, or is it better to start with an immune suppressive therapy? And this question is also different if you're younger or older, if you have a donor from the family, or if you have no donor from the family. But in a general way, you have, when you look for survival with bone marrow transplantation, a higher risk to die from transplantation. After that, you have a plateau, you will survive, and you have a very good chance for long-term survival. If you decide to do an immunosuppressive therapy with cyclosporin, eltrombopag, cortisone, or horse ATG, you have a lower risk to die early from your disease. But after 5 or 6 years, you have a relapse rate that is higher, you have higher need for transfusion, you have other problems that can appear. So after a few years, these curves will cross, okay? That's what you can see here. So short-term immunosuppressive therapy has a lower side effect range, but it's a long-term, your survival is often better with transplantation. This is a general remark. You can not say it for everybody. You have to apply it for every patient in a specific way. And what is also important, survival is one important thing, but quality of life is also very important. Quality of life is very equal between these two therapy options. So at the beginning, quality of life is poor after transplantation, but at the long term, quality of life is as good as for immunosuppressive therapy, because you have also restrictions when you have immunosuppressive therapy only. One important thing after transplantation is the question if you have a graft versus host disease. I will explain a bit later what that means. Graft versus host disease is not a good thing for somebody who has been transplanted for aplastic anemia. And if you have an extensive graft versus host disease, then you have also a lower chance to survive, because there's a lot of long-term effects if you have too much graft versus host disease. I want to explain you graft versus host disease because it's very important also for the long-term follow-up, because it intervenes every time when you discuss about transplantation. What does it mean? You have your body and you have an immune system inside of you. And your immune system has learned during your childhood to make the difference between foreign, that means bacteria, virus, fungal infection, and your own tissue. Your own tissue is not attacked by your immune system. Okay, if your own immune system attacks your own body, it's called an autoimmune disease. It's a kind of disease, but normally that doesn't happen. If you have transplantation, the immune system coming from the donor will still recognize bacteria and fungal infection and virus, but even when we have a good donor, 10 out of 10, that's what we say when we have a good donor, we have not the same immune system despite a good donor. So this new immune system will sometimes also recognize the body inside he is working, and so he can develop a transplant reaction against the body inside. The new immune system will now work. And this is what we call a graft versus host disease. So the graft, these are the stem cells that has been given by the donor versus against the host. You are the host as a patient. And the development of a graft versus host disease is more frequent when you receive stem cells coming from peripheral blood, because you have more lymphocytes in this collection than when the cells are taken from the bone marrow. This is why we prefer bone marrow as a source of stem cells in patients affected by aplastic anemia. And when you discuss with other patients transplanted not for aplastic anemia, but transplanted for leukemia or lymphoma, this is different, because a patient transplanted for leukemia, he will say, I have a little bit of graft versus host disease, it's good for me, because the graft versus host disease will also work as a graft versus leukemia effect. And this is good because you will cure your leukemia. But as a patient with an aplastic anemia, you don't have a malignant disease, you don't have a kind of cancer. You just need a new immune system and new stem cells. You don't want to have a graft versus host disease. So this is important to know, because when you discuss with other patients in the waiting room, they are maybe happy to have graft versus host, but you don't have to be happy about graft versus host. And to control this part of transplantation, you will receive as a transplantation immune suppressive medication at least for 4 to 6 months. In about half of the patients, we can stop this immune suppressive medication after 6 or 12 months. But in at least half of the patients, they have to take immune suppressive therapy for years or even sometimes lifelong. Okay, so this is also important to know. Graft-versus-host disease is a kind of abstract item, but it's very real. Acute graft-versus disease of the skin. Here's a mild form, here's a more severe form, and it's really like a severe allergy, well, what you can see. Okay, so skin is very often affected by graft-versus-host disease in the acute form. But more impressive, I find it's sometimes a chronic graft-versus-host disease. Chronic graft-versus-host disease can affect your eyes. You have dry eyes, you have wet eyes, they are painful. You can have graft-versus-host disease in your oral cavity. You have ulcer in your cavity. Your nails can be disturbed. You can have thickening of your skin in a way that you can move correctly. Yeah, your joint will be limited. Graft-versus-host can affect your lungs and also sometimes your joint. Okay, so you have problems to move. Okay, so extensive graft-versus-host disease, and this is extensive graft-versus-host disease, is a mess. We want to avoid it, especially in patients affected by aplastic anemia, because you don't need it. Okay. I had to explain graft-versus-host before we discuss about long-term follow-up, because we'll often see, there is again graft-versus-host disease. This part about long-term follow-up is not designed for patients with aplastic anemia. There is a specific reason for that. If you look here, transplantation, the most frequent indication for transplantation is acute myeloid leukemia, myelodysplastic syndrome, etc. And only about 5% of all transplantation is done for non-malignant disease. And aplastic anemia is a non-malignant disease. So, and there are other diseases inside this representation. So aplastic anemia is less than 5% of all transplantation that is done. So there were no really specific recommendations for long-term follow-up for aplastic anemia patients. Okay, just, you know, it's for everybody after transplantation. Part of long-term follow-up is the monitoring of the relapse of the disease. This is easy in aplastic anemia. You have to look in your blood cell count, and you know if white blood cells, and platelets are okay. So this monitoring of relapse of the disease. I will talk a little bit of general health maintenance and a little bit about monitoring for late transplant complications. So not every center doing transplantation has to do its own cuisine to know how to do long-term follow-up. There are recommendations. I took them here from a journal here in Germany, but they are also the same everywhere in Europe. Okay, and you have to look a lot of things when you come to our department for long-term follow-up. We have to look the immune system. Do we have graft-versus-host disease or not? We have to look the eyes. You have to go to the eye doctor in a regular way. The ears are very limited side effects. The mouth is very important. I will show you some pictures about that and doing some recommendation also for your skin. Endocrine system is very important. Okay, the liver can be affected by transplant. Your cardiovascular system is really important because you have a higher risk of developing coronary artery disease, especially in patients that have been irradiated. Your lungs can suffer. Okay, this is rare. It's because it's difficult to treat. Your nervous system, it's rare. Okay, good that it's rare. But there are also some psychosocial aspects that are important and I will talk about. There is a schedule for long-term follow-up, and you can see one schedule. I've compared our schedule with the one coming from Seattle. I don't know if you know that, but Seattle is the origin of stem cell transplantation in the world, and they are giving recommendation about long-term follow-up, and they update their recommendations every 2 or 3 years. It's an excellent source. You can find it by Google. If you introduce in Google long-term follow-up and Seattle Fred Hutchinson Cancer Center, you can find it. You can download it very easy. And you can see here, sometimes patients ask me, why I have to come so long here, and they have to be here for 10 years, for 20 years. And this is because there are recommendations, there are problems that can appear really late after transplantation, and normal house doctor, general practitioner will probably not recognize these problems. Okay, what does it mean, general health maintenance in transplant patients? It's important for everybody, but it's more important for patients after transplantation because you can really avoid long-term problems, and it's important to maintain your healthy situation, and you can really do something against these problems. People after transplantation have often a higher blood pressure, so they have to control it and to look and to treat if there is hypertension. Cholesterol is really very important because when you look cholesterol level before transplantation, after transplantation, there is a difference of 30 to 50 milligrams. Okay, your cholesterol is higher. And so if you have a higher cholesterol, you have a higher risk of cardiovascular disease. And a lot of patients after transplantation need drugs against high cholesterol. Statins are the most popular and the most frequent drugs given for high cholesterol. People after transplantation have higher risk for diabetes, so they have to look glucose levels. Also important, screening for colorectal cancer. Every patient who has been transplanted and has received chemotherapy has a higher risk for a lot of cancer types. But lots of these cancer types, when they are detected early, can be treated and can be cured. If they are detected at a late stage, it's a problem. Colorectal cancer is the best example. If you detect it early, it can be cured in most patients. If you detect it in a late stage, it's difficult to cure. So screening for colorectal cancer, we recommend it for every patient after transplantation, starting at the age of 40. In the general population, it's 50 years, we say 40 years. A man has to go to the urologist, women have to go to the gynecologist, and also screening for breast cancer starting at the age of 40 or 25 years after irradiation. Okay, cervical cancer is also important to detect. What is also part of the general health? In the first few months after transplantation, most centers recommend low germ food. Okay, and a lot of transplant centers have really given very restricted advices about low germ food in the first few months, or sometimes even for years. There is change in this field. There was a recommendation in 22 given for Europe that you don't need low germ foods in a very restrictive way after transplantation. There are new data, and there is no longer a strict recommendation for low germ food. We have really enlarged our food recommendations the last few months, and we just say, be careful, try to have fresh food and not food that has been somewhere in your house for weeks or months. Avoid sushi in the first few months after transplantation. Avoid to eat ice somewhere that you're not sure that it has been cooled correctly. So it's much easier now than 1 or 10 years ago. Okay, so recommendations are much less restrictive, and it's good. It's much more important that a patient after transplantation can eat and can have pleasure to eat, and will wait a little bit of gain, because most patients lose weight during transplantation phase. Okay, 5% is usual as a loss of weight, because you have lost muscles. Okay, and so it's very important to say that restrictions are not as severe as it has been 5 or 10 years ago. Healthy diets, that's clear. No smoking, and no smoking is important, because if you continue or if you start to smoke after transplantation, you have a much higher risk to develop side effects of your lungs, not only cancer, but also emphysema and bronchiolitis obliterans, and this is really a mess. Same for your liver, because your liver has suffered from transplantation, and if you drink a lot of alcohol, not a good idea. The same is true for other drugs. Sun exposure is important, because after transplantation, you have a higher risk of skin cancer. And the same is true if you detect it early. It's easy to treat, but it's also easy to avoid a lot of skin cancer if you use sun cream protection factor 50, okay, not 5 or 10, 50. It's important to do vaccination against the most frequent viruses and bacteria. And there is a clear recommendation, it's nearly the same in the US and Europe, for vaccination. Like, it's nearly the same then as a small child starting at birth. Hormone replacement is important, because lots of women that have been transplanted will suffer from early menopause. It's very frequent, and we recommend that patients go to the gynecologist, and we have a gynecologist specialized in this field, and they receive hormonal screening 6 to 12 months after transplantation, and we discuss with the gynecologist what is the best hormone replacement therapy for this woman at this age, if this woman wants to have children or not. So a lot of factors influence the choice of drugs, and it's important for different things. It's important to avoid osteoporosis, but it's also important to avoid cardiovascular disorders. It has a lot of effect on psychological comfort, and it has also an effect on sexual function. So hormone replacement is important. You have to discuss that, especially for premenopausal women, but also for postmenopausal women. Men, it's easy, because a lot of patients will have azoospermia, so they are no longer able to give birth to child. It's very frequent. We recommend a spermiogram 6 to 12 months after transplantation, and then recommendation by a urologist. And hormonal replacement is also important, also to avoid osteoporosis, also to avoid cardiovascular disorders, psychological comfort, and sexual function. It's easy to detect. It's just a specification of testosterone levels in your blood, and you can see if there is a need or not. There were also questions about fertility and pregnancy after transplantation. And if a woman is young enough to have children, there is possibility to have children after transplantation. It can be that you have had a chance to have oocytes before transplantation. Okay, this is the best way, okay, to have a pregnancy after. And if you look here, you can see here that there are also sometimes spontaneous pregnancies. So without oocytes that has been taken away before transplantation. But you can see here, if you had a conditioning, so the treatment before transplantation, with high-dose chemotherapy, with myeloablative conditioning, you have no more chance to have a spontaneous pregnancy. This is different if you had dose reduced conditioning. You have also a higher chance to have a spontaneous pregnancy. Okay, because you have to discuss. I cannot tell everybody now if he has received MAG or WIG. You have to discuss with your hematologist what I have received before transplantation. What is it? Was that a reduced intensity or was it a MAG? Most patients have received a MAG transplant conditioning regimen, but there are options, and you have to discuss that with your hematologist and also with your gynecologist before doing transplantation. Osteoporosis, I mentioned it when I was telling about hormone replacement therapy. It's really important because the risk of fractures is really something that will only appear 5, 10, or 15 years after transplantation, okay? But you risk hip fractures, forearm fractures. You can detect it easily by measurement of bone density. We do it every year. It's the beginning, every 2 years in the late stage, and you can treat it. Exercise, physical exercise is an excellent treatment against osteoporosis. You have to take enough calcium. Some people take calcium as a pill. We recommend to take calcium by food, by milk, by yogurt, by cheese. Okay, so it's better to take it by normal food. You have certainly to avoid deficiency in vitamin D. This is very important. If you have really osteoporosis, you can also give medication called biphosphonates or denosumab. It's very efficient, especially it's a long-term to avoid fractures. And hormone replacement therapy is part of the treatment of osteoporosis. So this is important. Risk of osteoporosis is not only depending on transplantation, but also on other risk factors like smoking, alcohol, autoimmune disease, but the most important is certainly transplantation itself. Thyroid is also important. We have to check thyroid function every 3 to 6 months to detect hypothyroidism. So it's thyroid function that has been decreased, but you can also see sometimes an increase in function of thyroid. And we have also to look, there is a higher risk for thyroid cancer. Symptoms of thyroid dysfunction is fatigue if it's too low, or weight gain if it's too low, weight loss if it's hyper, or heart rhythm problems also when you have a thyroid function that is really too high. So screening for thyroid function is easy and it's important. After transplantation, you have a higher risk for cataract, also at a young age. So, and especially in patients that received total body irradiation. You can also have a Sicker syndrome. That means that your eyes are really dry, okay? And this can also lead to conjunctivitis, so inflammation of your eyes, sometimes even with ulceration. That means if you have lack of conjunctiva in your eyes. And retinopathy, that means that you have problems really with to see, and it's also important. And you have to go to the eye doctor if it's necessary, if you have problems, okay? The oral cavity is really important. After transplantation, you have often a dry mouth. This is important. It can be due to lack of production of saliva, but it can also be due to an autoimmune disease that destroys the system that produces saliva. But you can also see graft versus host, again, graft versus host in your mouth. You can see here, this kind of lesion is typical for graft versus host, but also this kind of ulceration, okay? And that's why we look every time in the mouth of the patients, and we have to treat that. We can treat that, okay? You have also a higher risk of premature dental caries. You have to ask to a dentist to look for that. And there is also a higher risk for secondary cancer in your oral cavity. That's why you have also to say that to your dentist. He must check that, okay? Skin is a very important organ after transplantation. I've shown you pictures about acute graft versus host disease. You have to treat acute graft versus host disease by steroids, by other drugs, so you have to control that. Chronic graft-versus-host disease, you can have a kind of thickening of your skin. This is what we call sclerodermiform graft-versus-host disease, and it can be so severe that you cannot no longer move your joint. Okay, so this is important to see and important to treat by physical therapy, but also by other treatments. You can have pigmentation disorders. That means that your sky can be very white flakes of your skin, or it can be too much pigmentation. So you can have both of them. Sometimes it's the same patient. Okay, and you can also improve this if you avoid sun exposure. Okay, so that's also why sun exposure is not so good. Or if you have sun exposure, then take sun care at a good level. You can have problems with your nails. I've shown you one picture, and you can have problems, or this is wrong, with your hair growth, and sometimes also a loss of your hair. Okay, this is difficult to treat. If you have not enough hair, we cannot do a lot of things. And you have higher risk of skin tumors. That's why you have to avoid skin, and you have to go to the dermatologist every year. This is also important because skin tumors detected early can be treated easily, but if it's detected late, it's difficult to treat. So last part of the presentation, it's mental health. Aplastic anemia is a bad disease, and if you are confronted to that, not surprisingly, some patients develop depression, anxiety, and you are at the beginning, at least at the beginning, you have to stay at the hospital, you have a decrease in your physical activity, and especially after transplantation, you have for weeks or months, sometimes months, you have a decrease in physical activity, and you have also a change in your body image. This is not surprising. Fatigue is a real problem for aplastic anemia, and especially after transplantation. You will also suffer from a loss in your social integration. That means family, friends, but also very important, loss of employment in lots of patients. So you have to learn to be strong. You have to learn resilience. It's important that you have to look for that with family, friends, but also with your hematologists, with a team of psycho-oncologists. There's nothing malignant in aplastic anemia, but it's the same team in our center that is looking for these patients. Nurses are important. So it's important to try to have people that help you. One important thing is exercise. So if it's possible, continue to do exercise. We know that exercise is good for your bone marrow. Regeneration after transplantation is better when you do exercise. Okay, it's not good to stay in your bed. It's better to do something with your body, to do cycling or jogging or something easy. It's better for your bone marrow and also for your mental health. There are studies that have shown that exercise improves transplant results if you do exercise before transplantation, during hospitalization, and also when you are going home. So every period is better when you do exercise also at every time of this period. During the hospitalization, it's not always easy to do some exercise, but we try to give the opportunity with physiotherapists that come to the room, and we have a bicycle in every transplant room, and we recommend strongly to do exercise after discharge. Okay, we prescribe physiotherapy. We recommend really patients to do exercise. It's the best what you can do against depression and also against fatigue. There are studies really showing that. It could even improve results of the transplantation. Patients that do exercise have a lower non-relapse mortality than patients that are not doing physical exercise. So this is really an important recommendation. Fatigue is also a big problem after transplantation. You can see here, just looks a gray color. This is the proportion of patients having severe fatigue before transplantation. Here at admission hospital, here at discharge, and here after 3 months. So during the transplant phase, you have most patients having severe or high degree of fatigue, but it must improve after time, okay? And you can improve it again. The best treatment against fatigue is still exercise. Employment, don't be afraid if you need 1 or 2 years before you go back to your employment. You see here one study with 56 patients working full-time, part-time, or being students before transplantation. You see here 1 year after transplantation, more than half of the patients are still not working, okay? 2 years after transplantation, 2/3 of the patients are working again, okay? Good. So it takes time to go back to work. Okay, and this is my take-home message. Long-term results are good, okay? It's just the first 2 or 3 months that are the most important. Long-term follow-up is really important to detect complications early and to avoid long-term consequences, okay? Healthy lifestyle is important, and mental health remains an issue, but can be improved by different ways. And the best way is to having family, friends, exercise, and maybe also psycho-oncologist or some other kind of help. Okay, that's what I have prepared, and I'm ready to have questions.
Thank you so much, Professor Jost. That was really interesting. And let's see if we can start into some discussion. We have one question that came in from Nina. She got transplanted in August 2022 at the age of 30. And today she says she lives almost a normal life, except for one topic. What would be the reason that only the red blood cells don't recover? She still needs 1 transfusion per month. And is it more recommended to continue transfusion or to switch to injections of RNS? I suppose that's erythropoietin.
It's a kind of erythropoietin, yes.
Yeah. So she gets 2 injections up to now. Or is that weekly, Nina? Do you want to?
It's weekly, most patient-specific weekly, yes. Okay, so anemia is sometimes a persistent problem. You have to show what is the reason for the anemia. Is it really an EPO deficiency? And you can measure it easily in your blood, your erythropoietin level, okay? If there is not enough erythropoietin in your blood, the best way to treat it is to give RNS or some kind of these drugs, okay? So, and you have to do it for 6 to 8 weeks before you know if it works or not, okay? So it takes a little bit time to know if it works or not. Another reason for anemia persisting after transplantation can also be that there was a mismatch in the blood group between you and your donor, okay? But your center probably knows that, and they can measure if there are still antibodies against the blood group of the donor in your blood, okay? If you have antibodies against the blood group of your donor, you can also treat that, okay? You can treat that with other antibodies called rituximab or daratumumab, okay? So this is important to know. So the first thing, EPO level. Second thing, is to look if there was a blood group mismatch that can explain the problem. If you don't have these two reasons, sometimes it takes time, and red blood cells are often the last cells that normalize after transplantation. So maybe it will improve with time, okay? We don't do it only for anemia, but sometimes giving L-thrombopag can also help red blood cells to improve, okay? But it's an off-label use. You cannot do it in every country.
So Nina, do you want to reply to that directly? See your hand is up.
Thanks, Pascale, for reading my question. So yeah, I'm Nina, and I had these questions. So actually, we are still searching for the reason why I'm not producing enough red blood cells. So after 8 months, we switched to the injections of Anaresp. So I got the doses for 1 month, so quite the high doses, and it works really good because I produced a lot of red blood cells after, but as soon as this month has passed, so the hemoglobin is going back down.
Mm-hmm.
So that's actually I'm still, maybe I should say as well that I'm still on a quite high doses of cyclosporine.
Mm-hmm.
We did not start the reduction so far. And I was just asking myself if there could be like a link between the fact that I still take the high doses of cyclosporine and the fact that the bone marrow is still not producing enough red blood cells.
Mm.
But actually, I feel a little bit lost because I changed center. So I got transplanted in Hamburg, Germany. And today I live in France. So my doctor knows me like for some months now.
Okay.
And all the papers, but yeah, the fact that she doesn't know me that well, it's like complicated to start.
Yes. Okay. How many times you took every Anaresp, you said?
I got it 2 times now, and it was the 500 milligram dose for 1 month. So it worked really good. I felt like great. I did sports, everything. But after this 1 month, we had like the curve going back down. So I got another doses now.
Yeah.
And
But you have to continue with that. If you're starting with Anaresp and if it works, you have to continue, okay? And if your hemoglobin is above 12 or 12 and a half, the doctor must stop, because otherwise you risk to go too high and you risk thrombosis. But if you start this treatment, you can do that for 3 or 6 months to maintain your hemoglobin level above 10. Stop if you are above 12, and then after 3 or 6 months, you can try to stop, and sometimes your bone marrow is improving his function during time after transplantation, and you can probably live without Anaresp, okay? High doses of cyclosporine are not a direct reason that you are still suffering anemia. In very rare cases, but probably they would have detected that, you can have some kind of hemolysis due to cyclosporine. So hemolysis means that you destroy part of your red blood cells, okay?
Is it the LDH in the blood result?
Yes, LDH level is high
because
in this case.
It's always very low. So
Okay, so probably you have no hemolysis. Yeah.
Okay, and the risk, because like the RNS, the injections, they have also kind of side effects, which I kind of feel a lot.
Yeah, okay, good.
So,
most often it's well tolerated.
Yeah,
okay.
Maybe it's because it was the high doses.
Yeah.
Maybe I should try the lower doses, but more often.
It's better to have a lower doses, for example, 60 milligrams every week, and to maintain this level, than to have 500. 500 is a lot. So we often start with 60, and this is often sufficient to have an effect. Okay.
Okay.
So lower doses will be better tolerated.
Okay. Yeah, and I
Where
also
are you living in France?
in Pays de la Loire, so it's at the Atlantic coast. So it's Nantes. Nantes is the city where there is the hospital with a specialist for aplastic anemia.
Yeah.
So I feel quite comfortable with my doctor. She's very she's an expert, but it's just the fact that she doesn't know me that well. So
yeah, okay, good.
I'm still like doing some research in parallel.
Okay, because if you need an advice somewhere in France, there is in Paris there is Régis Latour. He's the France guy for aplastic anemia. He's really known in whole Europe for his expertise in this field.
Yeah.
If I have really difficult questions in aplastic anemia, I give a call to Régis.
Yeah. I think
he's a nice guy.
He was actually the one that gave us the connection to Nantes.
Yeah.
Yes, indeed, because Régis is the coordinator of the French network of aplastic anemia.
Yes.
So I'm sure that your physician is in contact also with Régis, because I'm sure your center is one of the member of the French network. But if not, if by any weird chance this is not the case, please write to us and we will create a connection if by any chance there is no disconnection.
Yeah. Thank you very much.
To you.
Are there more questions?
Any more questions? If not, I would actually raise one, and it's about slide 35. It's about the data on fatigue pre and post transplant. And I would like to ask if the group of the population that has that they measured this on, are they actually leukemia or aplastic anemia / PNH patients? This is probably more general, right?
It's more general. It was not a population of patients only with aplastic anemia. It was leukemia. It was everybody coming for transplantation. Yes. Yeah. This is not specific to aplastic anemia, but the clinical situation for a patient with aplastic anemia is not so different from leukemia, from aplastic anemia for this part of for fatigue and these long-term effects, because a patient with aplastic anemia has also fatigue before transplantation because he has anemia, he has transfusion need, he has infection complications. So it's not so different. Okay, most patients with aplastic anemia have fatigue before transplantation.
Exactly, but I actually, my theory is that also is the fatigue before transplant is also connected to the disease itself, to pathophysiology of it. Because when I had the transplant and I was still in hospital, and like only a few weeks later, I did have still fatigue, and I was not like complete, didn't feel healthy directly, but I felt a change. There was a change in the type of fatigue, or some levels were not as fatigued as anymore. And I still live with a little bit of fatigue sometimes now, but I would probably rather say I need more rest. Maybe that's age as well, but also the fatigue that I lived with before is not there anymore in that.
And the problem of fatigue is especially an important issue in patients suffering aplastic anemia and PNH. Patients suffering PNH have very often a real fatigue problem. And they say often very early after transplantation, after 2 or 3 months, I feel better now than during the last years, okay?
Yeah.
Because the PNH clone will disappear, and this will deliberate a lot of energy in your body. I was sometimes impressed when somebody 2 or 3 months after transplantation told me that he feels better now in a very early phase of a transplantation than 5 or 10 years before transplantation.
Yeah, exactly.
This is typical for patients suffering aplastic anemia and paroxysmal nocturnal hemoglobinuria. Yes.
So that applies to me, definitely.
Yeah. Okay.
Do we have any more questions? Did you understand everything?
Hope so. Otherwise, ask questions.
Yeah.
There is, okay.
So maybe you had one slide about the hormone replacement therapy, and I think that is something very important, but sometimes I feel that it is not covered so much in every hospital. And I wish it would be more included. So as I understand, you do that in Aachen very much, and you have a specialist for that.
Yep.
What would you recommend a patient to do if he or she realizes that in or prior to the BMT, there are no discussions on this?
You have to find a gynecologist who is really open to this discussion and who is a little bit specialized in this field. You need somebody who has really a profound knowledge on that. We send every patient there if it's possible. Sometimes it's difficult because patients with aplastic anemia have severe thrombocytopenia, but it's not a reason to not try to take oocytes before transplantation, but you need somebody specialized and really an infrastructure also to make the technical part of these procedures. Okay, and 10 or 20 years ago, you had to have a partner to do that. Okay, you need to be married or to have a friend or something, somebody who was able to do fertilization after you had taken the oocytes. This is not true now. Okay, you don't need to have a partner. You can do it also by your own, and oocytes will be taken away and can be fertilized later. Okay, so this has changed during the last 5 or 10 years.
Okay. So how would you find somebody like that, gynecologist that's so specialized?
They have also some kind of association, but I can try to find a website or something like that. I will ask to our Nele, okay, if she has a good network or something like that, so you can send it. To your people. I will ask for that.
Thanks.
Okay?
That's a great idea. If anybody has questions on that, then please contact me directly. Yeah. So Nina, you've got your hand up again, I see.
Yeah, thank you. I wasn't able to take notes during your presentation in the beginning, so I would like to ask if it's possible to get like the presentation to read.
Yes. I have sent presentation to Pascale Burmester, I suppose, and also to Maria Piggin. You can have the slides, no problem.
Yes, and also the video will be available together with the slide. They could be downloadable from our website. So both video and slides will be available, yeah.
Thank you. And to the question about the gynecologist, I don't know.
Gynecologist.
In English it's too difficult. like I
Je
got.
parle aussi français, mais c'est pas pour tout le monde alors.
Thank you. I try to adapt. I went to Amides, and I know that they are not not only in Hamburg, they are also in Düsseldorf, and I'm not sure if they're in other cities in Germany, but Amides is quite like a kind of good address for, for all the questions before transplantation. So I really got, they explained all the options I have.
For cryopreservation.
Yeah.
Yes.
And even more, like there are other options as well. So I really had the feeling that I had a kind of whole picture. All the options. So I can really recommend that.
Yeah. We have also sent some patients to Düsseldorf to Amides. Yeah, it's correct. Yep.
Well, I just can add all the, echo all the good feedback we received in the chat. And I really would like to thank our speaker today for having shared their expertise with us. Thank you very much. And also the audience for being here and having nourished the debate with your curiosity, question, and sharing of experience. So really thank to all of you for today's session. Thank you.
It was a pleasure. You're welcome.
Thank you. Have a nice evening. Bye-bye.
You too. Bye.
Bye.
Thanks a lot. Goodbye.
Bye.
Bye.